All right, in this explainer, we're diving deep into the pathophysiology of some really key gastrointestinal disorders. This is going to be a graduate level look, so we'll be breaking down the complex mechanisms, what these conditions look like clinically, and of course the strategies for managing them. It's really meant to be a comprehensive review for those of you who are advanced students.
So here's our roadmap for today. We're going to kick things off with acute pancreatitis. Then we'll get into IBS and celiac disease, really contrasting the two. After that, we'll talk about the dietary strategies for managing them. Next up is inflammatory bowel disease, or IBD, and we'll wrap it all up with a head-to-head comparison of Crohn's and ulcerative colitis to make sure those differences are crystal clear.
Okay, let's jump right into our first module, acute pancreatitis. This is a really serious inflammatory condition, one that needs fast diagnosis and management. So we're going to start by digging into its core pathophysiology and what it actually looks like in a patient.
So what exactly is acute pancreatitis? Well, at its core, it's a sudden, intense inflammation of the pancreas. And what's driving it is this really destructive process. The pancreas's own digestive enzymes get activated way too early. This leads to something called autodigestion. I mean, the organ literally starts to digest itself. And the two biggest culprits that kick off this whole cascade? Usually it's gallstones or chronic alcohol use.
Okay, so let's connect that mechanism directly to what the patient experiences. It all starts inside the pancreas, when enzymes like trypsin fire up when they shouldn't, causing immediate tissue damage. This sets off a chain reaction. You get intense local inflammation right there at the pancreas, but it doesn't stop there. It can trigger a whole-body systemic inflammatory response. And that whole process is what gives us the classic symptoms, that severe upper abdominal pain that, characteristically radiates straight to the back. Of course, you'll also see nausea and vomiting. And if things get really serious, that systemic response shows up as a rapid heart rate, tachycardia, and low blood pressure or hypotension.
So how do we actually diagnose this? Well, we look for some key biomarkers in the blood. You'll see both amylase and lipase levels go up. But here's the crucial thing to remember. Serum lipase is way more specific for pancreatic damage. It's the more reliable indicator. Then, to really see what's going on, to get a look at the inflammation and figure out how severe it is, we often turn to imaging, like a CT scan, to lock in the diagnosis.
All right, let's shift gears and move into our second module. Here we're going to compare two very different intestinal disorders, irritable bowel syndrome, which is a functional gut issue, and celiac disease, which is an immune-mediated problem. The goal here is to really highlight the fundamental ways their pathologies differ.
First up, let's talk about irritable bowel syndrome, or IBS. Now, the most important word to understand here is functional. IBS is a functional disorder. What does that mean? It means that even though the patient is having a lot of symptoms, if you were to do an endoscopy, there are no structural problems. The gut looks perfectly normal. The issue is with how it works, its function. We're talking about things like altered gut motility and something called visceral hypersensitivity, which basically means the gut is extra sensitive to pain. The thinking is that this all comes down to wonky signaling in the gut's own nervous system, and stress often plays a big role in messing with that signaling.
Clinically, IBS shows up as a pretty distinct set of symptoms. You've got recurrent abdominal pain, a lot of bloating, and this is a big one, changes in bowel habits. And that change can go a few ways. It could be mostly diarrhea, mostly constipation, or even a mix of the two.
Okay, since IBS is a functional disorder, we can't just find it on a scan. The diagnosis is all about symptoms, and for that, we use something called the Rome IV criteria. It's basically a checklist. So let's walk through it. First, the patient has to have recurrent abdominal pain, on average at least 1 day a week for the past 3 months. Second, that pain needs to be linked to at least 2 of the following. It's related to going to the bathroom, it's tied to a change in how often they go, or it's tied to a change in what their stool looks like. Third, the symptoms needed to have started at least 6 months before you can make the diagnosis. And finally, and this is absolutely crucial, you have to rule out all other organic diseases. You have to make sure nothing else is causing these symptoms. Now, in complete contrast to IBS, celiac disease is not a functional disorder. This is an immune-mediated enteropathy, basically a disease of the intestine caused by the immune system. And the trigger is super specific. It's an immune reaction to gliadin, which is a protein found in gluten. But here's the thing, it doesn't happen to everyone. This reaction only kicks off in people who are genetically susceptible, meaning they carry specific genes like HLA-DQ2 or HLA-DQ8.
So what's happening on a cellular level? Well, you can think of it as an autoimmune attack. When someone with that genetic predisposition eats gluten, the gliadin part of it activates specific T cells in their immune system. And these activated T cells then go on to attack and destroy the intestinal villi, those tiny finger-like projections that are so important for absorbing nutrients. This damage, which we call villus atrophy, just wrecks the gut's ability to absorb food properly, and that's what causes malabsorption.
Interestingly, how celiac disease presents itself can look quite different in kids versus adults. In children, you often see the more classic GI stuff, diarrhea, bloating, but you also see clear signs of malabsorption, like failure to thrive or short stature. In adults, though, the picture can be a bit more mixed. Sure, you can have diarrhea, weight loss, and pain, but sometimes it shows up in more subtle ways, like an iron deficiency that you just can't explain.
The diagnostic pathway for celiac is pretty clear-cut. It's a two-step process. First, you do blood work, serologic testing, to look for specific antibodies, like anti-TGIGA. If that comes back positive, you move to step 2, a duodenal biopsy to get a direct look at the tissue. And that's where you'll see the classic villus atrophy. As for treatment, there's really only one answer: a strict, lifelong gluten-free diet. But the good news is, for the vast majority of patients, sticking to that diet allows those intestinal villi to heal and grow back.
So that leads us perfectly into our third module, where we're going to focus specifically on the dietary strategies that are so absolutely central to managing both IBS and celiac disease.
When it comes to managing IBS, one of the biggest tools in the toolbox is the low FODMAP diet. Now FODMAP, that's an acronym, and it stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Phew! Basically, these are all short-chain carbs that some people have a hard time absorbing. So what happens? They get down to the colon, and the gut bacteria have a feast. They ferment them really quickly, which produces a lot of gas, bloating, and pain. So cutting back on these can bring a ton of relief. Beyond that, other key strategies include things like just establishing regular meal times, cutting back on common irritants like caffeine and alcohol, and being smart about fiber intake, adjusting it based on the main symptoms.
Okay, but for celiac disease, the dietary management is, well, it's non-negotiable. It's absolute. We're talking a strict, lifelong, 100% gluten-free diet. There's no wiggle room. That means eliminating all sources of wheat, rye, and barley. Patients have to become detectives, reading every label because gluten can hide in so many processed foods. And let's be clear, a low-gluten diet just doesn't cut it. It's not enough. And on top of all that, they have to be super careful about cross-contamination in the kitchen to avoid triggering that immune response.
All right, now we're ready to move into our fourth section, and we're shifting our focus to inflammatory bowel disease, or IBD. We're going to break down the two main types you need to know: ulcerative colitis and Crohn's disease.
Let's start with ulcerative colitis, or UC. Now, the definition here is packed with keywords that are absolutely critical for telling it apart from Crohn's. So UC is a chronic IBD with, number 1, continuous inflammation. That means it's one long, uninterrupted stretch of disease. Number 2, the inflammation is superficial. It only affects the mucosa, that very inner lining. And number 3, it's strictly limited in location to the rectum and the colon. At its root, this is all caused by a dysregulated immune response in that mucosal layer.
So when you think about that pattern of inflammation, the clinical picture makes perfect sense. The absolute hallmark symptom of UC is bloody diarrhea. Patients also often feel a sense of urgency, have abdominal pain, and experience tenesmus, which is that awful, persistent feeling that you need to have a bowel movement even when you don't. To confirm the diagnosis, you need a colonoscopy with a biopsy. And what you're looking for is that classic finding: continuous, superficial inflammation with absolutely no signs that it's gone deeper into the bowel wall.
Okay, now let's talk about Crohn's disease. And just like with UC, the keywords in the definition are everything. So number 1, unlike UC, Crohn's can affect any part of the GI tract, literally from the mouth to the anus. Number 2, the inflammation shows up in a skip lesion pattern. Think of it as patches of diseased tissue with healthy tissue in between. And number 3, and this is maybe the most important distinction, the inflammation is transmural. It goes through the full thickness of the bowel wall.
Clinically, Crohn's often presents with abdominal pain, diarrhea which might not be bloody, plus significant weight loss and fatigue. And that deep transmural inflammation is exactly what leads to the signature complications of Crohn's. Things like fistulas, which are these abnormal tunnels that form between organs, or strictures, which are narrowings of the bowel. For diagnosis, you'll use a mix of endoscopy, imaging, and biopsies to find that telltale evidence of patchy transmural inflammation.
Okay, so we've looked at both of these conditions on their own. Now for our final module, let's put them side by side.
This is a direct comparison to really nail down the key differences between Crohn's disease and ulcerative colitis.
This table really lays it all out beautifully, so let's just walk through it. First, location. For Crohn's, it can be anywhere in the GI tract and you get those skip lesions. For UC, it's only in the colon and rectum, and it's a continuous inflammation. Next, the depth of inflammation. Crohn's is transmural, meaning all layers are involved. UC is superficial, just the mucosal layer. Now, this directly impacts the key symptoms. Crohn's is more about abdominal pain and weight loss. UC is defined by that bloody diarrhea and urgency. And finally, the complications. That deep inflammation in Crohn's leads to things like fistulas and strictures. In UC, the big worries are toxic megacolon and an increased risk of cancer down the line.
So that brings us to a final question, something to think about as we look to the future. We've seen today that both IBD and celiac disease are, at their very core, problems of immune dysregulation. So if they share that common root, it makes you wonder, could we one day develop new immunomodulatory therapies that target the shared inflammatory pathways in both of these diseases? Could we find a way to unify their treatment? It's a really powerful idea to think about. Thanks so much for joining me for this review.